Start. Okay, we're recording. So for those of you who haven't attended before and don't know me, I'm getting organized here, which I didn't do before. I'm Rita Markowitz, and I'm involved in the Teledermatology in rural Georgia project here at the Georgia Cancer Center. So I welcome you all. And if I can, why didn't I get this ready before? I will be co-facilitating today's session with Dr. Doug Patton there. And I would like everyone to put their screens up, their cameras on, so we can see each other. That's one of the purposes of Project ECHO, is making communities. So it's good to be able to see who we all are. I want to introduce people. So first of all, I'd like to introduce our TeleDerm clinic healthcare providers. So if you are here as I call your name, maybe you could have your camera on and wave. So we have Dr. Sam Whaling from Lee Medical Arts. I haven't seen his name. Lori Hutchins from EGHC Mount Vernon. I saw her name. She's up there somewhere. Yes. Maisha McFarlane from EGHC Soperton. Is Sabrina Watkins from EGHC Evans. Stephanie Kathryn and Carolyn Jones, they're here, from EGHC Baxley. Floyd Soriano and Phyllis Solomon from EGHC Metter. Billy Stout from EGHC Sylvania. John Ferrier from Wadley. And Dr. Tracy Rosenbaum and Michael Sane from AAPHC Edison and Dawson. So these are our clinic people, and we welcome you. And then I want to welcome other people. We should have residents from AU's Department of Family Medicine. We have our dermatologist, Dr. Loretta Davis, Dr. Harold Rabinovitz, and Dr. Kendall Buchanan. There may be some derm residents out there, and we definitely have some medical students on board. And then here in our hub conference room in the Cancer Center, we have Kenza Mamuni, and we have Brenda Santiano, and the three of us are manning the controls here, and we have a medical student, Rashi Agrawal. So we're here and you're there. I think we ask that everyone indicate in the chat who they are, what their names are, and the name of their clinic, and what else do we put in? Oh, and your email address, of course. So if you could do that, and there are examples in the chat. And so I think now we can go to our slides.
There we go.
Okay, so here we are. TeleECHO TeleDerm Session number 15. We've been at this a while now. So the next slide, just what our agenda is for today. We've had our little introduction. Our didactic session will be given by Dr. Kathryn Potter from the Department of Dermatology here at Augusta University. And she will be telling us everything we need to know about Mohs surgery. And then we will have a case presentation by a fourth-year medical student, Disha Patel, and we'll have discussion and wrap up and so forth. So at this point, I will turn the session over to Dr. Doug Patton. And probably just about everyone knows Dr. Patton. He is the Dean of the Southwest Medical College of Georgia campus. And he spent most of his career as a rural physician, and he will take over now.
Well, thank you, Rhea. I appreciate everyone being here today, and grateful for the participation, particularly of the dermatology department and even the students and residents who are interested in this. We'll begin with a few announcements and just kind of review of things about ECHO. We go through this every time, so I'll move quickly. The basic thing is moving knowledge instead of people, and you see what ECHO stands for. Their next slide, please. So these sessions are designed to improve knowledge through telemedicine, using teledermoscopy as an example, teledermatology, but it's giving you at a local level the opportunity to use these distance learning techniques to improve your ability to provide care for your patients where they are instead of having to send them off. Next slide, please. So all sessions are recorded, as Rhea mentioned. By participating, you're consenting to be recording. And just a reminder that these are not HIPAA secure presentations, so please do not mention PHI in our discussions. These are not consultations, these are educational opportunities. Please be mindful of that. There will be information in the chat about CME and CNE towards the end. We do use data. We collect data through registration, through participation, through question and answers. The whole presentation is recorded and archived for future use, but we also use this data to help us to learn how to make each session be better than the previous session. So this is actually becoming, for some of the students and some of the residents, an opportunity for them to actually perform research on how we're doing with these ECHO projects. So next slide, please. General Zoom reminders: mute your microphone when you're not speaking, unmute when you do speak. Importantly, use the chat for questions during the presentations if you can. Raise your electronic hand if you need to interrupt. If there's something you just feel like you can't understand or it can't wait, then go ahead and raise your hand, open your mic, and introduce yourself when we recognize you. Keep your cameras on if your bandwidth will tolerate that. Some of us who are in rural environments have a little bit of a challenge with bandwidth capacity, so we understand if you need to limit this to audio. Gallery view is important so we can all see each other, and of course there's the emails for Kenza. You can always use the chat if you're having technical difficulties as well. Next slide, please. All right, so at this point, it's my privilege to introduce Kathryn A. Potter. Dr. Potter was educated through her medical school years at MUSC in Charleston. She then migrated south to Florida to do a year of medicine and then complete her dermatology training. And then she went the complete other end of the country on the eastern side, I believe, to Vermont to do her Mohs fellowship, and has come to herself and has returned back home. We're grateful for that, so that she's here to help serve us. But she's here today specifically to talk to us about what we as primary care providers need to know about Mohs surgery. With that, Dr. Potter, thank you for joining us, and I'm going to turn it over to you.
Yeah, thank you so much for having me. So I'm going to share my slides. Let me know if it doesn't work, but hopefully. Okay, are my slides up for everybody?
We can see them. Thank you.
Okay, great. Thank you. So again, thanks so much for having me. I have no conflicts of interest to disclose. So today our goals are to talk about what is Mohs micrographic surgery, to review AUC appropriate use criteria for Mohs surgery, and we'd recommend you refer to for Mohs, and then to discuss important high risk criteria for certain cutaneous malignancies. And when the alarm bell should be going off, you should be thinking about doing complete margin control when you're treating those cancers. So you biopsied a skin cancer, now what? In the majority of cases, when you have a non-aggressive, small, well-circumscribed tumor in a non-cosmetically sensitive area, we often can consider a lot of treatment options, which include excision, local destruction, and superficial tumors, and sometimes even topical chemotherapy. But there are situations when Mohs micrographic surgery is more appropriate. So we're going to go over those criteria soon. And I should also say, I worked on a book chapter with a medical student, Mishma Farsi, and Silas Money, one of our residents. So a couple of these diagrams and some of the words I used as well are from that textbook. So I just want to give them credit for some of the work they did. So what is Mohs micrographic surgery? It's a specialized procedure utilized for the treatment of cutaneous malignancies that meet the appropriate criteria. And often patients ask me what Mohs stands for, but it's actually just the procedures named after the physician who came up with the technique. His name was Fred Mohs. So in the 1930s, he started removing cancers, not skin cancers at first, but with this type of method, and then dermatologists adapted it and use it frequently now. So for Mohs surgery, we utilize sequential tumor extirpation with concomitant histopath examination by the surgeon via frozen horizontal sections. And I'll show you guys what all those words mean. We'll kind of go through what that looks like. It allows us to provide complete margin control for these cancers, resulting in the highest cure rate for indicated malignancies. And depending on the cancer and how it's going, it can also be potentially tissue sparing. So who performs Mohs surgery? Dermatology residents get a lot of procedural training during their 3 years of derm, including a lot of time on Mohs. But now the majority of us are doing an extra 1-year fellowship in Mohs surgery and procedural dermatology. And within the last several years, we also have a board exam we're taking. And you can find, if you're interested, a list of the fellowship trained Mohs surgeons. I just put the website there. I should mention, you can remove cancers and get them processed and have a pathologist review the slides while the patient's still open, but it's not considered Mohs surgery unless the surgeon is also the pathologist. So sometimes that's a little misinterpreted, but for it to be Mohs surgery, the surgeon removes the tumor and is also looking at the microscope and determining whether the cancer is all gone. So some examples of tumors. This is a basal cell inside a patient's ear. This is a well-differentiated squamous cell on a scalp, the first time it was biopsied. And this is a well-differentiated squamous cell on the left forearm. So 3 different cancers. We're going to talk about Mohs and then go back to these and kind of discuss which ones would be appropriate for Mohs and why. So what do we mean by complete margin control? When we do a standard excision, for example, on a small cancer on the back or the arm, we send it all for pathology and they bread loaf the tissue. So when they bread loaf the tissue, they're really only looking at potentially 1 to 3% of the total margin. And when they lay the tissue down, you can see here, for example, that if the tumor is still extending in section B and they're not necessarily looking there, then you're going to have you're going to be told you have a negative margin on the excision, but indeed you're still going to have some cancer that has not been removed. That is in contrast to Mohs surgery. So in Mohs surgery, we remove the layer of skin and we're looking at the 100% of the periphery and the depth of the margin. So when we do that, for example, here you see when we look at it, section 2 still has some cancer there. So we can go back directly where there's still cancer and take a little more skin. So by doing so, we're making sure all the cancer is gone. But also, for example, if you were to send off pathology or a specimen from an excision and it comes back with a positive margin, you have to go back and take another 4 millimeters around the entire scar. Versus in Mohs, we know exactly, again, where to go back and take a little bit more while the patient's still waiting. And then you can see here on the excision, again, if it's bread loafed in the way it shows in this diagram, then you're going to potentially have a positive margin, but a false negative result because it's going to come back as having negative margins when you still have some cancer there. So this is just an example of what Mohs might look like for a basal cell on the posterior ear. I remove the cancer and I ink it. So I'm the one processing the tissue. I ink the tissue on the right is red, blue is left, and then I freeze it down to a microscope slide. I then hand it off to our histotech. I make my little diagram so I know exactly what's left and right, up and down. They take it and they cut it in 4 micrometers, really thin pieces of the tissue and put it on a slide, and then they run it through a hematoxylin eosin stainer. So when I look at it under the microscope, you can see that that's my map, and then that's what the tissue looks like. So you could truly just place that microscope slide over the lesion on the posterior ear and see if there is some cancer there, exactly where that cancer is. In this case, it ended up being negative. It was clear, but that's what it looks like under the microscope. So again, I'm looking at the periphery and the depth when I'm examining the tissue. And if it was positive, then I have my map and I mark where it's positive and I take a little bit more. So we have family medicine rotators out here, and this is something we always talk about. When you biopsy a skin cancer, and if you're wondering, is it appropriate for Mohs or should I consider Mohs surgery? There's an app for that. So this is the app. It's free. And you basically just go through the questions that ask you. It's very self-explanatory, but you pick the cancer type. So, for example, if you say basal cell, and then you have to pick the location. And if you're unsure about the location, it has a little diagram for you. So I said we were in area H, and then you do recurrent or primary. And then it talks to you about, is the cancer aggressive or non-aggressive? And so again, if you have a question, there's a question mark there and you can see what's considered aggressive. And then you do the size, whether the patient is healthy, immunocompromised, or has any genetic syndromes. And then you get a score. So if the score is 1 to 3, then it's not appropriate to do Mohs. If it's 4 to 6, it's kind of in the middle. You might consider doing Mohs. I would say basically never do Mohs on something that doesn't meet criteria. So meeting criteria means that the score is either 7 to 9. And during training, I actually got a score for every single tumor before we treated it. We put it in our notes. Now I can basically tell you what the score would be. But again, if you had a basal cell, area H, primary nodular, healthy patient between 1 and 2 centimeters, then it's very appropriate to consider Mohs. Now, just because something meets criteria certainly doesn't mean that that's the be all end all and that should be their treatment. But I think it's often just a discussion that needs to be had with patients about, it meets criteria for Mohs. This is what it would entail. And then we go from there. I think often patients get upset when they find out that their primary cancer would have met criteria for Mohs and it was excised with a positive margin, and then they get sent for Mohs. Sometimes they would have rather just had it taken care of with Mohs to begin with. So we're talking about some important high-risk factors for these cancers. We talk about basal cell cancers, which of course are the most common type of skin cancer. Typically, if it's located on the trunk or extremity, if it's greater than 2 centimeters, then that's something that kind of makes you want to start thinking about considering Mohs, or if it has an aggressive histological subtype. So if it's infiltrative or sclerotic. Another kind of just rule of thumb I use, or I talk to the residents about, is if you were to take a 4 to 6 millimeter margin around the cancer and close it, do the repair, and then find out that you had a positive margin, would it be potentially catastrophic or very difficult to go back and take another 4 to 6 millimeters around what you removed? And if so, then maybe think about doing Mohs. Squamous cells, on the other hand, we often use the Brigham and Women's staging for squamous cells, and we talk about if there are 2 or more high-risk factors, we're considering them to be high risk of metastasis. And this may have been something you guys have already talked about previously, but if they're greater than 2 centimeters, if they're poorly differentiated, if they have perineural invasion, or if they invade beyond the fat. So often when you do a biopsy, you may not have all of this information. For example, you may not know how deep it goes until they come for surgery, but you certainly will at least know how large it is. And then it's definitely helpful if your pathologist can let you know about the differentiation, because that can give you a lot of information. Again, if the tumor has 2 or more of those risk factors, we do know that they have a higher risk of having metastasis, and you would probably want to consider complete margin control. And consider Mohs surgery. We also at MCG, we do Mohs for melanoma. Not all Mohs surgeons do, but we do offer that. We specifically use a MART1 immunostain, which highlights the melanocytes and helps us better tell where the melanoma is. Most frequently, we use it for melanoma in situ on the head and neck, but it's being used more often elsewhere. It does show a better cure rate than a standard excision. And this is just an example of what a MART1 immunostain looks like under the microscope. So instead of being the hematoxylin eosin with the pink and blue, as I said, the melanocytes light up a little bit better. It's a little bit easier to interpret. So if you're sending someone for Mohs for melanoma, probably want to just, know if they're doing an immunostate or not, because it can be super helpful. So this is an example of Mohs for melanoma. Melanoma in situ. So we take a 5 millimeter margin around the melanoma. We check it. I believe this was positive in one small area. We go back and take a little bit more. And when we're sure it's all clear, we're able to do the repair that day. So you can see how if you want to remove the tumor and want to wait for the pathology, that's a fairly sizable wound that the patient is waiting to have repaired. And not only that, but if you were to decide to do the repair before knowing if it was clear, if it ends up being positive, having to take that down and start over again or remove more can be pretty difficult. Okay, so now we're going to go back to the lesions we talked about for practice. So this is a 5 millimeter nodular basal cell in the right triangular fossa. So it's not superficial. So often, a superficial tumor, we might talk about topical treatment, probably not in this location anyways, but just a thought. But it's smaller, but based on the location, if we were to try to take a margin and close it primarily, that would be difficult. So it meets the Mohs AUC criteria. It's a 9, and this would be one that we would move forward with Mohs surgery. It's appropriate. Okay. So this is a 1.2 centimeter well-differentiated squamous cell on the left forearm. We can talk about our treatment options, but Mohs is not appropriate. So if you were to put this into the app, then that it would tell you right then, but I think we can all just kind of think about the fact that we could easily take a 4 millimeter margin around this with an excision and clear it. It's well circumscribed. We can tell where it starts and it stops. And even if we take that margin and let's say it was positive, to go back and take more would it wouldn't be fun for the patient, but it wouldn't be cosmetically sensitive area. It would be appropriate. You also could consider local destruction here. Typically with this size, I would probably go with an excision. And then this was a well-differentiated squamous cell in the scalp, but it recurred. And so now it's a 3 centimeter recurrent well-differentiated squamous cell in the scalp. So it's well differentiated. That being said, it's greater than 2 centimeters. And when I go to remove it, it's invading down to the periosteum, so invading beyond the fat. Therefore, it's Brigham and Women's stage T2B. So I would order a CT with contrast to go ahead and check their lymph nodes and consider adjuvant radiation once this is healed. So this is a more aggressive tumor that we want to treat appropriately. Again, as a Mohs surgeon, we do reconstruction. Typically, most Mohs surgeons will. We do it most often the same day after complete tumor extirpation. So benefit is we know the cancer is gone and then we can move tissue around. I would be hesitant if your Mohs surgeon is always sending their defects to someone else to repair, question if it's necessary. Also, if they're always bringing them back the next day, probably not necessary. Most of the time we can close same day. So just an example of when you are going to be moving some of the tissue around, you want to make sure that cancer is gone before you do so. And just to bring up, we do also treat other rare tumors. So on that app, you can certainly kind of play around with it and see, but this was an atypical fibroxanthoma that actually Dr. Buchanan had biopsied and sent to me. That we treated with Mohs. And so there are other tumors than basal cells, squamous cells, and melanomas that we treat, but those are certainly the most common. So that's just a quick overview of Mohs surgery, and I'm happy to answer any questions if anybody has any about the procedure.
Thank you, Dr. Potter. That was a great presentation. I'm looking at the chat. I don't see anything in the chat, but certainly we got a few minutes here. If anyone has a question that they would like to raise their hand or just open your mic and speak. While we're waiting, I did have one question about margins and melanoma, Mohs for melanoma. Does this change the net margin that you wind up having to take that you're satisfied with? Or, there used to be, sort of this rule of thumb that you had to have a centimeter. That's not always true on the face, obviously, and stuff like that. Does this allow you to deal with a smaller margin because you're looking so carefully?
So it's actually interesting. What we treat the most is lentico maligna melanoma, melanoma in situ on the head and neck. And actually, most of the research shows that we end up taking more than the typical 5 millimeter margin. I think the average is more like 9 millimeters to 1.3 centimeters because these just spread out. So they tend to want to track along the skin. And so that's why for, I think, some time, patients were having to go back to have repeat removals on the face. If they weren't having Mohs for those. Certainly we'll potentially take a little bit of a smaller margin on our first stage, especially for example, like on the eyelid or on a free margin, and see if we can clear it. But honestly, the majority of the time it ends up being as much as 5 millimeters for a melanoma in situ, if not more, on the face.
And you may have mentioned this, but I wanted to just throw out there for consideration. If someone has had an excision for melanoma and it had positive margins, particularly in these sensitive areas, is that a good case to refer for Mohs?
It is. So it depends. If it's an invasive melanoma, and it depends on the Mohs surgeon. Most of us are comfortable with doing superficially invasive melanomas, so up to 0.7. After that, we're talking about doing a sentinel node. So the majority of the time, we would send to a surgical oncologist who would do the excision in the node. But if it's something that we're going to take care of as a dermatologist, any positive margin on a melanoma is certainly reasonable and beneficial to do complete margin control with Mohs.
Okay, I like that term, complete margin control. We'll keep that in mind. Dr. Rabinovich has put a question in the chat. Are you using the Castle test for evaluation of your aggressive squamous cells on the scalp?
No, sir. I've not started using the Castle test yet for squamous cells. I feel like I have a pretty good, I'd follow Brigham and Women if it's greater than 2 risk factors. I honestly don't know that I feel comfortable not going ahead with CT and considering radiation. Especially, most of the data for radiation is with perineural invasion greater than 0.1 millimeter. So if they have perineural invasion, I'm probably going to recommend radiation. I don't know that the Castle test is really adding a whole lot yet for squames for me, but certainly probably be used in the future.
For those of us who don't know what the Castle test is, can you give us like a wee thumbnail sketch?
I can. So you can send melanomas and squamous cells out, and they look at Dr. Rabinowitz maybe can speak to more for the squamous cells, but they look at genes. So instead of they look at certain high risk gene profiles, and then they come back and tell us this tumor looks more aggressive or less aggressive based on their gene signature and their gene expression.
Perfect. We're getting better and better with genetics and cancer and stuff like that. We may just...
I definitely think in the future there won't be any question about us using it and not needing to radiate some of these tumors based on what it shows.
Perfect. One quick last question from Rhea before we move on. She wants to know, how long does a typical Mohs procedure take? And I guess that includes with and without reconstruction.
Absolutely. So that's a great question. I'm sorry, I should have said that. So when the patient comes in, we numb them just like when they have a biopsy. It takes maybe 5 or 10 minutes to do the first tumor extirpation, and then I take it back to the lab. It takes me 5 or 10 minutes to process it in, and then our histotechs are pretty fast. So probably 30 to 45 minutes before I'm looking at the slides under the microscope. So if it's clear, they're in and out in about an hour to an hour and a half. If it's positive, we do it all over again. So that adds another 45 minutes. I would say the majority of patients are probably a 2 or 3 hour procedure. Of course, we have those cases that go 4 and 5 stages. That's rare, but it happens. At which point they're with us probably half a day or so. And then the MART1 immunostain that we use for melanoma takes longer to process. So it's also a longer day for them. I don't get those slides back for another probably 2 to 2.5 hours. So they kind of hang out with us in Augusta for the day.
So we'll save the question for how in the world do you schedule your OR time with that kind of flexibility?
Well, I will quickly say we don't have to do in the OR. So patients are awake. and we do the reconstruction the same way with them awake in just a minor procedure room in the clinic. So that's a nice benefit of Mohs as well.
Okay, very good. All right, well, let's move on then. And thank you very much, Dr. Potter, for that. And it's my time now to introduce Disha Patel, who is I'm trying to find my script now. I'm a little bit like you, Maria. So anyhow, Disha is a fourth-year medical student at MCG, and she has a case presentation that she's going to share with us now. And I'm not sure who's running the slides for you, Disha, but I'm going to turn it over to you.
Thank you, Dr. Patton. I actually have my slides, so let me just share my screen real quick.
There we go. We can see that now. Thank you.
Okay. Any of you guys? Sorry, I had like my chat coming up. Okay. So thank you guys. Happy to be here and have this opportunity. But so yeah, I'm going to be presenting a clinical case for us this month, and let's get started. So our patient was an 83-year-old Caucasian male with Fitzpatrick type 1 or 2 skin, so very fair skinned. He had a history of poorly differentiated squamous cell carcinoma to the left lateral forehead, but he was just presenting to our clinic for just a full skin check. He didn't come in with any other prior concerns, just getting his skin checked for us. On exam, we noted a 4 millimeter reddish brown macule on his right cheek that the patient was unaware of, if you can see it on this picture. So just kind of coming up with a differential going from that, just initial thoughts. In the image, it did look kind of pigmented. Initial thoughts are kind of leaning us towards, you want to make sure that it's not a melanoma, so considering pigmented lesions. Some other initial thoughts for differential can be other benign things such as lichen planus like keratosis, seborrheic keratosis, solar lentigo. And then other possibilities, things that we might not initially think of, especially with a lesion that might look pigmented, would be a pigmented basal cell carcinoma and a pigmented actinic keratosis. Typically, these lesions aren't presenting pigmented, so they might come to us as a later or an afterthought. So just to kind of be aware of that, these are all possibilities, but the thing that's going to help us kind of differentiate which one it is most likely is going to be our dermoscopy. So on dermoscopy, here's just an overall image of it, and then I'm going to point out a couple of things. So on dermoscopy, you can kind of see these pinkish white areas. So you see that one of the most key clinical things you see is the arborizing vessels, which I'm going to point out right here. You can kind of see how they're kind of branching and arborizing. So these arborizing vessels are typically highly specific for basal cell carcinoma. So that's just kind of something to keep in mind. When we initially saw that lesion, it looked somewhat pigmented, might not have led us to basal cell carcinoma initially, but this characteristic on dermoscopy certainly does kind of lead us towards that differential. Some other things to kind of focus on are these focal leaf-like areas, which are a little harder to appreciate on this image, but I will show another example after, but kind of just looking at this right here. Also something that's another feature that can be kind of leading us towards that basal cell carcinoma differential. And also these focal blue-gray dots right here. So now that we've kind of seen our dermoscopy, it's kind of led us towards a basal cell carcinoma, but something that's going to help us kind of prove that is going to be our histopathology. So on histopathology, you can kind of see multiple superficial and nodular masses of these basaloid tumor islands, kind of making it consistent with a diagnosis of nodular basal cell carcinoma. You can also see peripheral palisading and hyperchromatic nuclei and scanty cytoplasm, all things which are consistent with that diagnosis of BCC. So that kind of proved our diagnosis of nodular basal cell carcinoma. So just some other features of BCC. So these are all things that we could see, some together, all of the above, or one or the other. You don't necessarily have to see all of these features, but kind of just showing better examples of the features we saw on our patient are these arborizing vessels. This is a better image of those leaf-like areas that wasn't as easy to appreciate in our image. And again, another image of like blue-gray dots and globules that are a little easier to appreciate in this other image that were harder to appreciate in our patient. Given the location of this patient's lesion on the cheek, it is a cosmetically sensitive location, which is why this patient was scheduled for Mohs on August 1st with Dr. Potter. So this patient did come in and did have his procedure done. This was the picture of the lesion prior to the surgery. You can kind of see where that biopsy was done and kind of had left that little scar. After they did the procedure, this was the final defect of the wound. As you can see here, and here's the final repair. It easily was able to be closed with a linear closure on the cheek. Should heal very nicely over the next few weeks, and over time, probably will be even harder to even really see the scar. So it should heal pretty nicely. So outcome. With the Mohs procedure, this patient has a really good prognosis, considering it was also just a basal cell carcinoma, which typically also just has a good cure rate and prognosis as well. Higher cure rate with the Mohs procedure, anywhere from up to 99%. And given this patient's history of skin cancers and his current skin cancer he just had excised, he will be seen for skin checks every 3 to 6 months. So kind of running through our other differential, just to kind of point out some key features and other things that could have maybe led us to believe maybe one of the other things on our differential. So if it was a solar lentigo, this is one type of solar lentigo where you might have seen a more, so a solar lentigo is basically a sunspot. On dermoscopy, you might have seen this more annular pattern or the scalloped moth-eaten borders. Another type of feature you might have seen on dermoscopy is a more reticular pattern, which is more kind of straight, slightly curved, long or short parallel, kind of fingerprinting type of pattern. But as you can see, this lesion is very organized, which also kind of leads you to know that it's a more benign lesion. This one is a seborrheic keratoses. A lot of us will sometimes call them wisdom spots. A lot of older people will definitely, you'll see these kind of stuck on lesions under dermoscopy. This lesion looks more orange because the patient had been using a vitamin C serum, which is kind of causing that pigmentation. But just to kind of point out some other features that are more characteristic of it are these fissures and ridges, along with these like comedal-like openings. And you can see how this lesion is quite sharply demarcated, which again, this organized structure is kind of leading us to a more benign lesion. Another one to consider is lichen planus-like keratoses. These are typically solar lentigos or seborrheic keratoses that are undergoing regression to some capacity. So you might know a lot of these diffuse gray dots and granules, kind of also called some coarse peppering, and again, that annular pattern. You don't really see any other features that are more specific to melanoma, which kind of reassures us that this is also, once again, a benign lesion. In a pigmented actinic keratoses, which are your precancer spots, a lot of times showing up as a pink scaly papule or a lesion on the patient. Something to remember is clinically and dermatoscopically, the scale that might be present is very much indicative of kind of helping you lean towards this differential. Along with this annular pattern, you can also see these evidence circles, white circles, and like the follicles, along with that moth-eaten scallop borders. These aren't all the features you can see in actinic keratoses, but just some of the ones that I wanted to kind of show today. Again, this is a pigmented lesion, which might have concerned us for melanoma, but again, you can see how organized this lesion is. And another characteristic that has been also been key to actinic keratoses is a red pseudonetwork as well. And then melanoma, the thing that we want to make sure that our lesions are not, this is what we're trying to make sure that we can identify and know how to manage. So off the bat, you can kind of see how disorganized this lesion is. You can see the irregular gray-brown pigmentation between the follicles, not really following any sort of pattern. You can see areas of these dark structureless areas that are kind of obscuring that follicular opening, kind of have that kind of obliterated that follicle almost. You can't really see it, you just see a lot of dark pigmentation. So kind of leaning more towards that melanoma features. You see the disorganization, multiple colors of brown. Some other things that you might even see are angulated lines and rhomboidal structures, which are kind of harder to appreciate in this lesion. But just kind of key thing to kind of look for would be that disorganization. So case summary, this case kind of highlights the importance of dermoscopy. If it wasn't for the dermoscopy, initially we might have thought it was like a melanoma considering the pigmentation of the lesion. However, on dermoscopy, seeing those branched serpentine vessels were highly indicative of that basal cell carcinoma, which our pathology then proved. So just a little question of how might have our management changed if the lesion was more suggestive of a melanoma under dermoscopy? Any thoughts?
Oh, this is audience participation.
Yes, sir.
That's great. Anyone have any thoughts about that?
I can help out. I discussed this case with Disha, and we were just kind of talking about how, you know, if you don't recognize those features that you typically see with a basal cell carcinoma, and you were concerned about a melanoma, with this example, we did a tangential shave biopsy, but with a melanoma, you would probably do more of an incisional biopsy, or this lesion was pretty small, so you could even have done an excisional biopsy. But again, you know, you see those arborizing vessels, you recognize it's a basal cell, easy peasy, patients in and out. And so I think it just speaks to how awesome dermoscopy is and how easy it allows you as the provider to make that diagnosis.
Well, thanks for that additional information. I'm watching to see if there's any other questions or comments in the chat. Disha, do you have other slides, or is that it?
That is it. But if there's any slides that you want me to go back to or something you want to take a second look at, just let me know. Otherwise,
absolutely. Well, thank you for that. So I think you summarized the case very well. And I do think it highlights, in addition to the importance of dermoscopy, it highlights the importance of us minding what Dr. Davis said earlier. We all have to see the skin. When we're seeing patients, it doesn't matter what your specialty is, we have to see the skin. So this would have been something that anyone who was looking at this patient for a normal checkup or anything, if they had taken just a careful moment as a primary care provider to look for something because of the high risk, might have been able to catch up on something. We know that best practice is for somebody that has a high risk of skin cancers to get that full skin evaluation on a regular basis, depending upon their risk. But that's not practical for everybody. So they're much more likely to wind up in a primary care office. So it's important for us to do that. Couple that with the fact that we've empowered people to have these dermatoscopes in their offices. You don't have to be a dermatoscope expert, because we have experts who will help you with the interpretation of these lesions. What we want to do is make sure everybody's comfortable using the technology and getting some of those lesions in, because even submitting the lesion for an opinion becomes a learning opportunity for all of us who are trying to understand better what our patients' skin troubles might be. So skin screening, dermoscopy to help with evaluations of the risk of the lesions and how they might need to be approached. Even in your case, the difference between a shave biopsy and an excisional biopsy All of those decisions were shaped in part by your ability to use the dermatoscope. All right. Any other questions or comments? I know Dr. Buchanan, you worked with Disha on this whole thing, and Dr. Potter, you were involved in the care. Any comments from either of you?
I don't have any. I appreciate y'all having us today. That was a great discussion.
It's great. Thank you so much. And I still don't see anything in the chat. I did see one thing. Amika Okora has signed in and it looks like it's from a Nigerian email address. Amika, are you with us still?
Yeah.
Well, it's good to have you. If you're actually in Nigeria, it's got to be getting close to midnight. We're having a little trouble understanding you, but I just wanted to say welcome to you as an international guest in our program. So thank you for joining us. So, all right. Well, with that, Dr. Davis, we were talking about your all-star team earlier. Do you have any last comments to share?
No, but I am proud of my team and appreciate this opportunity to share what we're doing here at MCG, especially in the Mohs clinic and with our dermoscopy. I don't think we talked about the fact that Mohs is very cost effective too. I think people would think, well, it's so expensive to do this, but because you don't have to keep sending your pathology down to the lab, many of these procedures are actually been shown to be more cost effective than traditional surgery.
Excellent point. And we're trying to do better and do it for less money. I think that's an extraordinarily important point. So thank you very much. Did you want to introduce your special guest today before we leave?
What? I did tell my husband to sign on. He's a physician, and I thought it'd be good for him to see what we're doing here and on TeleECHO. As you know, it's good for every specialty, as you mentioned.
That's right. This is great. All right. Well, with that, I'm going to turn it back over to Rhea for closing comments and instructions. Rhea, thank you. Well,
okay.
There we are.
This is a great discussion, and so I certainly want to thank Dr. Potter for the presentation, and Disha did a great job as a medical student, and so thank you very much, and thanks to people who asked questions and participated. So our next session will be on Monday, September 11th, same place, same time, 4 o'clock. And the didactic presentation will be Sun Protection Do's and Don'ts by Dr. Silas Money, right? And if I'm pronouncing the last name correctly. And there'll be a case presentation by our medical student, Mishma Farsi. And I also want to remind our the TeleDerm clinics to send us your consults, that Dr. Buchanan is ready to receive Molscope Derm Engine consults, so keep sending them in. And we posted the CME code here, which you can text to the number, and it's also in the chat. So I think that just about covers everything. Again, thanks to everyone who participated. And I want to remind our TeleDerm Hub people to stay on for a few minutes of a post-echo discussion. So thank you all very much for attending. And I think that our Project Echo guests can all sign off now. and we'll stay on for a few minutes. Thanks a lot. And we'll see you in a month.